I always say healthcare is data-rich information poor. There's too much data. And that means there's no dearth of data. There's a dearth of how do you, as you're pointing it out, how do you collate it? How do you interpret it? How do you make sense of that? The moment that we are in with generative AI is the moment that healthcare will benefit the most. We are seeing the traction because healthcare does move at the speed of trust. AI has been in healthcare for more than a decade. This moment feels different, James, because now technology is far advanced to help with that meaning making. Because of that, underneath frontier models being so advanced. I think that's very, very exciting time. Next 3 to 5 years will be fundamental transformation.
Hey everybody, this week I'm delighted to be joined by Aashima Gupta, who is Global Director for Healthcare at Google Cloud. She's on the board of directors for loads of different companies, previously Kaiser Permanente, JP Morgan, loads of cool stuff. Aashima, welcome to the Healthtech Podcast. How are you doing?
Glad to be here, James.
Excellent. Yes, because had to delay because you're a little bit unwell, which is going round, particularly in the UK. So much illness. So much illness. Yeah, people need spending cloud credits on solving the common cold, I think. But yes, we can probably get into that to see if there's anyone doing that. You're probably on the board of a company doing it, but I'm sure we'll get into it. But yeah, it'd be great for our listeners, Aashima, if you could tell your story, because obviously there's so much in there in healthcare and in technology and. Yeah, I mean, to get to a point, I think an enviable position, being a director for Google Cloud in healthcare. I think most people listening would certainly like to speak to you, if not be in your position. So, yeah, really interested in knowing how does one get to that position? Tell us about your career.
Well, thank you, James. It made me reflect. I feel very grateful to be where I am today. And like many careers, it's never been a straight line. So today I spearhead healthcare industry strategy for product and solutions for Google Cloud. And that means setting the direction for our product team, our solutions team, and working with healthcare leaders across the world to help them transform their business strategies to define either new models of care, revenue generation, and improved patient experiences. I've had 26 years worth of experience in growing, differentiating, and improving businesses through technology transformation. But technology is something that I've been passionate about for as long as I can remember. My passion in the computer science dates back to the days growing up in India when my dad first exposed me to a local computer science course, and it influenced me to get into computer science. So I did my bachelor's in computer science, master's in computer science. But the spark started much before. I bought my first computer. At that time, buying a full built computer was very expensive. And so I spent money in assembling the computer together. So from that point onwards, there's no looking back. I saw how this box, an intelligent box, could do things, create things. And that was my first interaction in getting deep into technology. And then having studied bachelor's and master's in computer science, my first job was a programmer, and I kind of grew through the rank. My first job was back in India, and then moved here in the US and got banking as my first project. It was with Fidelity Investments. I learned a lot. Banking is a fascinating field. We all deal with money, and this was about defined benefits, 401k, and building solutions there. And in 2008, personal reasons, my dad got pretty sick, and I lost him in a matter of a week. I had to go back to India, and that was my first foray into dealing as a caregiver or as a daughter. Understanding, I couldn't get his reports. So that made me much more interested in this world of healthcare. And I came back with a renewed sense of, we all want to solve problems. Like fintech, I was solving problems. What type of problem do I want to solve going forward? So that to me was a very recent moment in my own life that I want to understand healthcare. I want to go deep in technology, and we all are problem solvers. Critical thinking is important, but that's how I got into a big shift from a fintech to healthcare.
Well, in fact, let me just jump in there a second because I can relate to that. I've told this story a couple of times on here, but my brother passed away. He was a professor of cardiology, and he died of cancer during the COVID time, not of COVID, although certainly accelerated it. But yeah, I looked at my own career at that point as well, and actually, it's trying to find, a positive and a negative situation of actually just being kicked into a new life almost, or having, there's that phrase, isn't there? Only after you've lost everything are you free to do anything. And not that you've lost everything, but that there's a sense of that, losing a family member. There's a sense of loss that I think does give you this kind of freedom almost, because you for a temporary period, you're sort of not afraid of the consequences because you've got that calling of whatever that higher purpose is. It's kind of outshining all of the consequences for that kind of short period of time. So like listening to that and tuning into that it certainly did for me anyway. It definitely just kicked me into a slightly different. It's off the back of that I started SomX, the company that I've got now. Like and I'm not saying it completely is attributed to that, but I think there's a strength you can find in loss, isn't there?
Yeah, I think that was a trigger, and James, you hit that, right? I wanted to commit to a larger purpose. Can you work in a small way, make a difference to help people lead healthier lives? And what I can tell you about my journey in healthcare, when I moved from bank to Kaiser Permanente, you see a very different set of pace. What we very quickly realize is people in healthcare very, very mission driven. And it's how they spend their time, both inside and outside of work, how they devote their energy. And I find it pretty compelling. Like, not that I didn't like my time in fintech, that was work. This is very meaningful work. So you deal with the bureaucracy that healthcare is. You deal with the slow pace, because you do think and you do believe that a meaningful change will be very impactful, no matter how long does it take. So that drives you. And to your point, I think that was a turning point for me to go from a very fast-paced, you could argue one way or the other, but healthcare is not, it's considered to be a laggard industry. But that mission and the purpose I've never found in any other industry. And for me, there's no looking back. No matter what comes along, this is the path I've chosen, and I'm grateful for it.
Before I talk about KP, because your role at KP, by the way, looking at your LinkedIn, sounds right down my alley. Digital technology incubation and solutions sounds ideal. I want to talk to you about that in a second. Before I do, though, I actually want to take you back to India, and I want to take you back to that buying the first computer moment from your father. I think that's a really interesting one, because we were talking about it before we started recording, that I wish someone had looked at like what I was actually interested in and like thrust some of that upon me at a very young age to just see what I would do and perhaps influence my career choices. But it seemed like you had that moment. Were you one of the people that sort of broke it apart and looked at the innards, or were you one of the people that like really tested its capabilities from like a software perspective? Like what were you like with that first computer? Like what was like sparking you? What were you actually like passionate about and interested in with that first computer?
So I think there's a funny story to that as well, right? When my dad, when I was growing up, he was very forward looking for his time. So he wanted me to have a good career. And yet, instilled in me, figure out this field. This is going to be the future. So it was not like naturally I drove to technology being the career. So there was that inspiration from him. And also in Delhi, it gets pretty hot. And the computer labs used to have the only AC there is in the school or the college building. So naturally, I would spend a lot more time in the lab to escape the Delhi heat. And so that kind of grew on me. The more time I spent in the lab, the better I learned, and then we were from a very humble family background, so buying a branded computer was expensive. It was 3 or 4 times the cost. So the motivation was, can we get the computer built without paying the top dollar, meaning, and not in the Indian rupees in that case. So it was more means to an end to really get the same functionality. And so that was getting the computer at different price point, but also it made me more comfortable with different parts, different pieces, how different pieces kind of come together. And my first program was a basic program where this was back in the lab to print electricity bill or things, very smaller things. I said, wow, it could do these calculations.
Yeah.
Technology, if done right, is like magic. You connect to that moment, like, oh my God, this is, that was kind of the foray.
Yeah. It's incredible when you run the code and it works. The thing happens. You're right. It's indiscernible from magic, right? At a certain point in time, which that's one of those funny laws or whatever, isn't it? That technology should be, or brand new technology should be indiscernible from magic. Wonderful. So let's go back to Kaiser. So you're at JP Morgan, your life circumstances change, you desire a career towards healthcare. You get that with Kaiser Permanente. So how did that come about? What was the role and what did you go in there to do?
So I had come back from India after my dad's passing away, came back, spent 2 months figuring out. And Kaiser Permanente at that time had hired a lot of fintech executives. They wanted to run healthcare like with the same level of urgency as they thought that you get the discipline from financial, because that's where it was perceived to be moving at a much faster pace. So I knew some of my banking exec had joined, and I reached out to him, and he didn't have anything in his department, but he made some connections for me. And technology is such an equalizer, James. The project I was working on, the products I was using were the same products Kaiser was using. It was a middleware. I was responsible for, at that time, the middleware server. And so the skills matched. But instead of building web services for a bank or a credit card division, which I was leading in the bank, it was for, and at that time I was naive enough, it was to build it over an EHR called Epic. Like, I did that. And got into the job and very quickly realized it's nothing like banking at all. Technology being the same, but still the stakeholders are very different. I had not worked with physicians' leadership at all in the bank, and I didn't realize in that you build a technology, it solves a problem, you roll it out. The whole aspect of change management, it's there in the banking as well, but it's a completely different level in healthcare. So I had to quickly learn that it's not about creating a technology solutions. It is about how do they solve the problem for two big stakeholders. One is the patients, other is physicians, which was a very different kind of mindset. And I made my share of mistakes in Kaiser. I still remember when I was leading the digital, we were building this pediatric app for childhood obesity. It was a cause that Kaiser's a very mission-focused organization. And in wearing my technology hat, we built an app and to gamify that experience, that how much exercise you did, things of that nature. And I remember very categorically talking to a pediatrician, and they were like, Aashima, you're solving childhood obesity with an app? Meaning that the kids will spend more time on the app, sitting on the computer. It completely defeats the purpose. So then you kind of think back. You really, really need to think a very different, empathetic approach, being in the shoes of the patient, in the shoes of the physician, to really think of the solution.
Do you think so? It's quite interesting that you say that, actually. The comparison with banking, that it's less about just solving the problem and it's actually solving the problem, but now having to consider these stakeholders. Do you think that in some way the goal should be to simplify how easy it is to make decisions and solve problems in healthcare, or are they? I mean, are those extra complexity? How necessary are those extra complexities? Are we weighting this correctly? Do you think, like, based on the work you did at Kaiser, like, okay, you come in and of course the big stakeholders, the physician, the patient, of course, I get it. There has to be some weighting. What's your sense of how, like, is there an imbalance of power here of actually getting things done? Like what's your sense of that?
I think beyond those stakeholders, there's a lot of bureaucracy in healthcare in general, right? There's something to be said about, can we improvise the processes? So as an example, we had to, for digital, which was a new discipline at the time, we had to launch Process Light. That you don't need, 18 months to launch a new feature or new solution. That was not the model. And I think part of that is the way healthcare technology works, is a lot of custom off the shelf, like you're building on top of HR or a billing system. So I believe so you move at their pace, and they have so many clients, so you are kind of in a queue. So that was earlier on very clear to me, and part of the reason why I left Kaiser to join a startup was, after doing that for 7 years, you wonder, it's not moving fast enough.
Interesting, yeah.
Right? Because you can do the same thing. And to me, that software engineering discipline that exists in a tech company or in a startup, in a healthcare environment, that's very dependent on third parties. And I think that maneuvering that, creating a roadmap that aligns with that vendor's roadmap and your roadmap, that takes a lot of time.
So the startup that you joined, tell me about that.
So in Kaiser, one of the things I was launching was, and again, story there, my elder daughter is allergic to peanuts and any kinds of nuts. And so I have to be very careful with her. And as she was maybe in the middle school, and we had gone to Lake Tahoe for skiing, and we were coming back, and my husband was driving, and he said, well, I'm feeling sleepy. Let me find out near a Starbucks. So he pulls up his phone. We go to Starbucks. He gets his coffee. He gets 2 cookies, and we are off onto the highway again. We didn't know the cookie had nuts, and Anika started getting reaction. And like I was able to find a Starbucks near me using the app, I started to look for ER and hospitals near me. It was pretty complex at the time to find out the hospital that was open. We were in the middle of nowhere from the Sierra. So that led me to, and that, all the products are sometimes based on your own personal experiences. So I wanted to open Kaiser's location API, like what facilities are open, where, like, why is it so easy to find a Starbucks coffee versus a life-threatening situation to find which hospital is open at what time and with the services. So
what is the answer to that, by the way? Why is that?
I think because most of this information, in the case of Kaiser, was on the website. It was not easily available as an API. So
okay.
So you need to know, and that was my first, at the time, was opening that API, like really taking the functionality, which is already public, by the way, but can you not make it in the PDF? Can you make it electronically accessible to these concepts like API? And that was my foray into, I could do that. And then I was building in Kaiser. Another moment was the diabetes management, which was a huge disease burden from Kaiser Permanente in our patient population. And if you looked into the workflow that nurses called people, they had a panel of 1,000 patients or a defined set of patients. And for them to call them every 2 weeks. It's a 20 minutes call. Hey, how's your diabetes? How's your, glucose meter reading? Things of that nature. So very manual. So my first project in that disease management sector was this remote monitoring of diabetes, where we were giving the glucose meter with the connection, built it on the cloud, and watch the fluctuation in the readings, so that nurses, when they're calling, they have the data beforehand. Now, this is, I'm talking 2012. Now there's a whole bunch of startups doing that work. But even that, where there's a lesson in empathy I learned was day of the launch. It was a controlled pilot, 200 people we were launching. I was very proud of it as a technologist. Again, on the call, we had sent the playbooks of how do you use such a solution. And it was a beautiful looking book, bigger fonts. I was very happy. And first call, a gentleman picks up. He was from Colorado. And my first statement of that was open Internet Explorer, because I wanted him to use our website. And his question was, what? What Explorer? So it was, so we
Interesting. It's humbling, isn't it?
And this was a 70-plus-year-old gentleman dealing with diabetes, dealing with part depression. And now I passed off that burden to him, meaning that was, again, then we did the ethnographic studies. Who are the people who need it? What is the best way to deliver the solution? And I believe that's where technology sometimes fails in having that empathy for who's the receiver. Are we making it easy or hard for them to embrace it?
So what comes next?
So then I joined this Apogee, which was the API build company. So I had gotten good at working with EMR, figuring out the APIs that could be exposed to build experiences like I was building on the diabetes management. That was 2-year journey with. And in that, I got exposed to interoperability, because now I became much more on the product side that would be used not just by one hospital, but many. And got more exposure into this whole interoperability wave, the FHIR records and APIs, that it's not enough to open APIs. You actually need semantic interoperability. That's what the FHIR standard did. So as an example, if you're talking about building an app ecosystem, like we all know there's an app for everything, right? Today in the app ecosystem, if you go, but how those apps connect to your patient record, if it is a bespoke connection each time, that's where the cost adds up. That's where there's no standardized way to connect to that system of records. So there was a lot of body of work with ONC here to standardize those APIs. So for clinical records, patient is called patient API, your demographics, conditions. So they had figured out few clinical concepts and the way to call it the same. That way, no matter your hospital A or hospital B or C, you're calling patients the patients. So those were the APIs. So I launched the interoperability FHIR accelerator in Apogee, and within, I think, 18 months, we got acquired by Google. And that was my entry into Google. And in Google, as you know, is a amazing company where it's very consumer focused. And Google Cloud was a division which was focused on the enterprise. That was my world. How do you take the amazing technology that is built by Google and make it meet the enterprise? So I call myself as Chief Translation Officer. We have incredible tech, incredible engineering resources. And if the world can get even the fraction of that, we would profoundly change the trajectory of how this technology can be embraced, built at scale.
Amazing. So there's something that I want to ask you about here, semantic interoperability. So you said it's not enough to just have APIs. You need semantic interoperability, i.e., everyone needs to speak the same languages. All the systems need to speak the same languages. If you clock a patient in, all of that stuff needs to be interoperable with everybody else that's also recording that stuff. And then you can get interoperability across sites, you can get interoperability between hospitals, you can get interoperability across the network. So that is a wonderful concept. And you're absolutely right. FHIR standards absolutely have clearly and obviously helped with that. I think one criticism of healthcare is just how messy the data is, and actually how much data we just don't actually capture. The amount of beeps, the amount of words that disappear into the air. There's so much data that we really struggle with. I'm interested, because I understand that problem through the lens of being a clinician. My mind always goes to intensive care, and I can just sort of see all of this data just disappearing, but actually loads of it being collected in intensive care, because actually you've got an arterial trace, you've got a CO2 trace, you've got an O2 trace, we've got everything there. You've got venous pressure, you've got like anything you could possibly want there. Yet still, there's people talking to each other in the corridor, and there's like a blood gas machine over there that for some reason isn't connected in, or like whatever. Like there's lots that I see even where we collect the most amount of data. As a technologist that is in healthcare, where do you think we are, and where do you think we're going with this? Like, are we entering a world where we're starting to collect a lot of this data, in which case, how many semantic languages do we have, or do we need? Like, what's the size of the mountain here? Because I see quite a lot of startups coming up, particularly ones that, because my eye's on it, with, we can take a load of intensive care data and we can start to predict decline. And, some have done okay, a lot haven't. So it seems to be a problem that isn't easily solved. But clearly with enough data, the problem can be solved. It's just that I'm not sure how close we are to collecting it, let alone in a standardized format, and let alone sharing it across multiple sites, hospitals, organizations, companies, groups, etc. So I'm interested in your view, I guess, from a technologist's point of view, how you see that problem and where we are and how it might potentially be solved.
You painted a pretty accurate picture. I often say
something I thought about a fair amount, if you hadn't noticed.
Yeah, I can totally tell. You've given it a thought, and I always say healthcare is data-rich, information poor. There's too much data, right? And that means there's no dearth of data. There's a dearth of how do you, as you're pointing it out, how do you collate it? How do you interpret it? How do you make sense of that meaning making from that data? And to me, we talked about FHIR earlier, but FHIR is just one subset. That's just clinical record. There's data coming from devices, as you mentioned. There's data coming from our wearables, our glucose meter. These are called patient-generated data. And there's data in claims, in your financials, where, what treatments were given to you. All that is just one subset. Then you talk about imaging, like CT scans, X-rays, MRIs, completely different data modality. So to me, healthcare has been on this journey for electronic. We moved from paper to electronic. Now we're moving from electronic to digital. And I believe the moment that we are in with generative AI is the moment that healthcare will benefit the most. This is the industry. This is the complexity of data standards for different data formats. So we talk about multimodal in Gemini. Multimodal means that inherently, in this case, a plug for Gemini, but it's important to understand that it is a very tall order to ask everyone to now comply and make and harmonize to one thing that people will continue to build. What multimodality in the context of large models means that they inherently understand different signals. And because Gemini was trained from the very beginning on images, on text, it's able to find the nuances and correlations. So we have technologies like semantic search now, where the burden is search is figuring out how these concepts relate together. So to me, AI has been in healthcare for more than a decade. This moment feels different, James, because now technology is far advanced to help with that meaning making. Because of that, underneath frontier models being so advanced. And I think that's very, very exciting time. Next 3 to 5 years will be fundamental transformation we'll see in healthcare.
3 to 5, interesting. I'll come back to that. So we made it, 28, 29 minutes before generative AI was mentioned. So now we can actually start the podcast. So yeah, you say it's an exciting time. And actually you said 3 to 5 years. You mentioned Gemini, you mentioned multimodal. We know that there's, MedPalm 2 and there's obviously lots going on at Google. Why don't you tell us what your role is at Google? What you do now as Global Director for Healthcare at Google Cloud. Tell us what you do. Tell us what that means. And then tell us your relationship with models like Gemini and MedPalm and all that sort of stuff. And we can go into that.
Yeah, so my role, as I mentioned, is a Chief Translation Officer. I work with, Google is an incredible company with amazing talent, researchers, engineers all across the company. So when they hire someone like me who's come from the industry, my job is to figure out which technologies will resonate the most to solve a given business problem.
Yeah.
So I work in that case. So for example, let's take Gemini, and when we heard that the frontier model is able to, for example, it's a very good example where it was given a silent movie, James, which was a 45-minute silent movie, no audio or movie. A Gemini was able to ascertain the plot, the characters, the storyline,
right,
with no word spoken. Like it's able to understand. Now you take that powerful a technology. Now you think in terms of healthcare. What is the implication? And to me, healthcare is inherently multimodal, right? You don't just see a CT scan or an X-ray. You see a human, you see an individual, right? When you go to a doctor, they see you, they see how you are, your physical,
correct,
mental status,
how you've walked in the room, what the pitch of your voice is compared to normal, and this, by the way, that multimodality is exactly why it's going to always struggle to build trust in this opening phase with clinicians, especially clinicians that have been around for a long time, because that perception piece that like we all as human beings will just assume we're incredibly good at it, better than any computer can do. Even I'm struggling to be like, could this thing spot something before the person sits down like I could? I mean, the answer is absolutely yes, and if not now, it certainly will in the next 5 minutes when it doubles in power. So yeah. Yeah, but no, you're absolutely right.
I think, but to me, I think what healthcare is much more than multimodality, meaning multimodality is understanding the context of the patient completely. But that healing, that judgment, that empathy, I don't think machines can do that. So we believe very strongly that this will be your very powerful assistant that has collected the data for a physician. So take another example. We talk about population health, reaching the population, and take breast cancer as an example. Let's say as a hospital population health executive, I want to reach out to all the female who are from the age 45 to 55, have family history of breast cancer in the clinical notes that they have shared that information with us. They have a health plan, they're eligible for screening, but they haven't gotten it done. If you want to run a query, you're touching 6, 7 different systems. So to me, it's not about diagnosing whether I have mammogram missing cancer or not. Of course, the models are getting advanced in aiding that diagnostics as well. But in healthcare, we're starting from very, very humble beginning. Can I collate the data and then figure out the trends for a patient, then level up for a population, level up to different communities? So I used to, in Google, we say inpatient is a failure. Outpatient is a failure of health at home. And health at home is a failure of community health. So the more when we believe in that prevention mindset, that means we need to collate this information much, much more earlier than at the end when you're now in the hospital or in the inpatient. I think that's where we have failed. So not all diseases fall into the same category, but if you believe in that paradigm, that of prediction, of prevention, that means collating that different modes of data and making sense of it, finding the trends, figuring out, and AI now is now getting into that realm. These models are very well advanced. Um, and here's the difference, and I call that um, big AI versus small AI, meaning we had built AI systems like we've been doing in Google Healthcare for a long time. And in traditional predictive AI, you collected all this data, you labeled it, you then built the model, you trained it, and it gave a score. Now the general purpose models are so advanced that they've been pre-trained. But what they lack is the evaluation. I think that's where the burden is. That's where the effort should be in what are the evaluation framework that the output that these models are creating is grounded, meaning it's grounded on the truth, it's citable, it's not black box, you know where the information is coming from. And how have we built this evaluation framework? And that framework would differ on how this technology is being used. If you're writing a discharge summary, have nurses, clinicians involved. Like, what does a good summary look like? Right? So getting that human feedback loop, we call it reinforcement learning by expert feedback, not just a human feedback. So getting those experts defining how would they evaluate the output of that model, as an example. So to me, the frontier models have significantly lowered the barrier of building this technology and building into healthcare, different parts of value chain, be it revenue cycle, financial, all the way to diagnostics, where we are seeing the traction because healthcare does move at the speed of trust change. So you need to start healthcare. So you need to bring the stakeholders along, and not every project is a GenAI project. Some projects are good for predictive AI. So I think that's where I think a lot of discipline and governance needs to happen. And having that very thoughtful approach on where you will apply AI, where you will apply generative AI, where you will apply now, we talk about agents, which is the next step. And I think that distinction is critical. And to me, my other concern is I think this is a new level of engineering. Right? This is not, this, things are moving much, much faster. Like this is every 3, 6 months is new advancements. So now it's not going to be just one model or the second model or the third model. They'll keep coming at a much rapid pace. How do you then create an abstraction layer where you can plug in what makes sense to you? But what doesn't change is that kind of platform, that how I will embrace or adopt or absorb these different technologies in my workflow.
Yes. So many excellent questions in there and so many excellent points. So the first thing I want to talk about is AI versus Gen AI versus agents. All of this is getting conflated in the term AI, and this is causing us a big problem. And it's interesting what you just said, actually, about what is the platform onto which these models come and are audited for their ability and for what they can do and for their evidence and for their capability and all the rest of it. It's almost like now there needs to be, per site or organization, a group of people or technologists and people that understand the clinical as well to work together almost to be this platform, to build this platform, to act as this platform almost, but to certainly be a filter. Because it seems that, I mean, does that fall into the remit of a CIO? I guess. But it's almost like this is a super specialist role. It's almost like this is a mixture of the CIO, the CCIO, and a group of computer scientists and a group of clinicians that are early adopters of the AI, Gen AI, and agents, and they might be doing it in their alternative lives outside the hospitals. And actually, all these people need to come together and have a sensible conversation about what are we going to implement, how are we going to implement it. But to your point about a platform, like, what is our baseline philosophy here? How much evidence do these things need to come in and do a job? How much does the need to be before we adapt that evidence requirement? What if the opportunity of bringing this in is so great that actually it's unethical not to do it, and actually we really should be? And that actually is I think probably one of the most important things you've said about this platform, this filter, this philosophy, this group of people, like whatever you want to call it, that the pace that we're moving is so great that it's frightening almost to me. It's so exciting, but it's also so frightening because I don't know where this falls with like medical device like certifications and like obviously in the US FDA and here MHRA, and like, are we going to see these models regulated as class 3 devices? Like, is that ever going to be a thing? That obviously makes people comfortable. If not, then okay, we can split clinical and non-clinical, and we can think about, let's just deploy as much non-clinical as humanly possible to speed everything else up. But we don't leave that clinical behind, because to your point, with more and more and more data, this is an absolute sitting duck for a decent model to come in and start diagnosing rare disease, telling us the best investigations, telling us the most likely diseases by differential percentage and all this sort of stuff, or directing care and exactly to your point, freeing up clinicians to actually deliver the 2.5 types of empathy that AI can only deliver half of quite well, half of one quite well. So I definitely agree. I just wonder, like, I guess my question, what do you think we're ready for now? Even when you think back to like KP and where you imagine KP to be now, and not them specifically, other hospital groups are available, etc. But like, what do you think we're ready for in the short term? Where do you think like these, AI, generative AI, and actually I'm really interested where you think agents might be deployed, like now, if not already. Like, what do you think's going to be first over these hurdles and over these lines?
That's a great question, James. And we spent considerable amount of time talking to the healthcare leaders, like where are they seeing the opportunity? And one thing is clear, that there's many parts of the value chain where the technology can be applied, but not all projects are generative AI projects. Right? Not every, so unrealistic expectations can lead to wasted investment. It can lead to misallocated resources, and too many pilots, too many AI models will just further complicate it. So we need to focus on proven high impact use cases where there's an ROI. So I'll give you some examples. Last October, we did a Harris Poll survey about growing burden of admin tasks in healthcare. Now, it's not the most glamorous place to start, but I can tell you it's very impactful. So, for example, we talk about burnout. What is a burnout? When you talk, it's reading, writing, documentation. And healthcare industry is facing this crisis of paperwork. When you talk about doctors, nurses, administrative staff, they're drowning in this paperwork. And just to give you some stats, in that survey, clinicians said they spend around 28 hours a week on admin tasks. Like 28 hours in a week. And perhaps not surprising, but Medical office staff spends around 34 hours per week, and insurance claim staff spend about 36 hours a week. And there's a direct link between too much admin work, burnout, and staffing shortages. And we all know, like WHO gave a report out, there's a shortage of 10 million healthcare workers by 2030. So, you walk back from that reality that if we are seeing the trend line that there will be a shortage of 10 million healthcare workers, you need to plan for it now. And you need to create the capacity. It's not that you're going to all of a sudden create more schools. We should do that for sure. But you need to know where in my value chain am I giving? Are they working at the top of their license? This is a term we use a lot. When you double down, what we found is paperwork takes, when it's where you're spending the most time, patient care often can take a backseat. But what if technology like as powerful as generative AI could shift the balance back in favor of human connection? In the survey, when we asked healthcare workers in how they feel about AI helping with the admin work, more than 90% of healthcare workers across the industry feel positive about this. And to me, the areas where GenAI can reduce errors in healthcare by automating tasks prone to human error, such as data entry, clinical documentation, billing, doing it at scale where a human, look at all my notes for thousands of patients and tell me if I made a mistake. This is a scale AI is good at. And to me, that's where we are seeing our customers innovate. A good example, we work with Meditech. They are an EHR company. They are using AI semantic search for their Expanse EHR at Mile Bluff Medical Center. And what they found was in the pilot setting, clinicians are able to save around 7.5 minutes per visit because they are able to search the entire patient record and get a summary. To me, that's much more humble use cases of AI because each time you visit a doctor and many times you come to hospital from a different clinic, there's a 600 to 800 words notes. And if you're dealing with a chronic condition, maybe you're making those visits more. So you have each visit 800 words, 10 visits in a year, go on 5-10 years. Now you have plethora of 40, 50 pages document about a patient. Now it's unrealistic to ask a human clinician or nurse to make sense of it. And to me, that's where GenAI is a smart assistant to you to figure out, okay, these are the nuggets. And by the way, these are the citable references. We worry a lot about hallucinations. So that trust, safety, grounding is critical for that. So we are seeing use cases like that, like 7.5 minutes per patient is a huge saving for them. And it's not, again, in diagnostic, is much more in the back office. Similarly, we are seeing with Highmark Health, they are using prior authorization. And as we were talking with the executive there, one of the stats they shared stuck with me. It was 30% decrease in missed lunches.
Huh.
So those
that's
lunches,
very real, isn't it? That's very real.
Right. So instead of writing manual prior authorization requests, they were able to have more lunch, peaceful, don't miss a lunch to do this work. 18% increase in discharging before 11 a.m. They have a hospital arm, so timely discharge could mean, when you talk about bed management, they saw that. And so to me, same with HCA, we're working with them on nurse handoff. Like that handoff today takes 75 minutes. Can we use it? And at scale, these small incremental changes are transforming because they have a profound impact on where people are spending time.
I think that's really interesting. There's a few things I want to mention here. So handover that you just mentioned, oh my goodness, the amount of time, my entire career in healthcare and digital health and health tech, whatever it's been called along the way over the last 15 years, people have been trying to solve handover. It's the messiest problem to solve. And actually, there's a guy called Elliot from a company called Infinity, that I can remember him talking about this. That you try and solve handover, and the problem is you start pulling the red thread of handover, which is basically, okay, what is handover? Handover is a group of tasks that have accumulated during your shift that you haven't managed to complete, that you need to tell the next person about, that are all connected to a patient. Right, fine. So let's make this quicker. So we need to understand the task more. Cool. Where did the task emerge? Okay. Why didn't the task get done? Okay. Interesting. And then you go a bit further, like, okay, well, if that's the reason the task didn't get done, then can we speed that up? You end up getting further and further and further back. And eventually you've built an entire task management solution that basically is the only way to actually solve handover. The reason I explain that is because I think you mentioned a humble use of AI. I think that is that's a cool phrase, I think, because I think we could all think about more humble uses of AI like handover rather than jumping to drug discovery the whole time. And, these things that are going to change the world genuinely, that are already happening, by the way, but there are real problems right now. And again, using the word you use, at scale. There are these problems happening at scale. These margins at scale make a huge difference that clearly there's a need for AI for. The other thing I just want to call out with my comms hat on and my marketing hat on is that headline, 30% decrease in missed lunches, is a stroke of marketing genius, because we talk about all the time about speaking to the audience that matters in their language. My goodness, there is nothing that speaks to a clinician more than losing a pen or missing their lunch. Or someone stealing your pen, shall I add, because you never frankly lose it. You put it down and someone else picks it up, especially if it's a nice pen. So yeah, I think 30% decrease in missed lunches is a wonderful, wonderful phrase to use. But again, humble uses of AI, I think is a very, very, very interesting thread. I think generative AI, you're right, has a place and has certain specific places clinically, but non-clinically, we really need to be thinking about this a lot. And I think a lot of where people's minds are going to at the moment is clinical. You mentioned earlier, we all have personal experiences of healthcare with ourselves, with our families, and we all want to, all of us that are sort of amateur generative AI users, Gemini, ChatGPT, Perplexity, like we're all sort of amateur AI users, really. You're a technologist that really understands this stuff, and it's interesting where you're sort of weighting your excitement towards these kind of marginal gains of the humble use of AI, particularly in the non-clinical world and all that sort of stuff. So yeah, it's fascinating to me. And I think especially with you've mentioned this before, but we're generating so much data in the community as well. And there's so much emphasis on prevention that it's only natural, I think, for lots of people to try and skin a generative AI model for something out in the community to help with prevention, sort of bill it as a lifestyle thing so it avoids regulation and get it out. And all of a sudden it's telling you what type of headache you've got. And is it telling you to take paracetamol? Is it not? Is it saying that's generally the done thing? So there's lots of obviously risk and stuff and loads happening. But I think with so much happening, we're going to start to cut the wood from the trees. I'm interested in agents. I'm interested in what you think about the agent model, because this is another area where I think the ceiling is, well, you get to an exponential very, very, very quickly when you think about the agent model, because as soon as you've got agents talking to agents and generative AI talking to an agent, which talks to a generative AI, which talks to another agent, all of a sudden, could you algorithmically solve healthcare? that is sort of my moonshot question. Could the agent model at scale eventually solve healthcare?
So I would say again, go back to my humble use cases, and just to put a perspective on your previous point, in HCA alone, there are 40,000 handoffs in a given week. So imagine Out of
Yeah.
75 minutes, you say 5 minutes, no more. It's very, very conservative. 5 minutes.
Mm.
Multiplied by 40,000 is 200,000,
Yeah.
which is 800,000 minutes.
And it's actually, by the way, I just want to jump in. It's actually, I agree, it's the minutes. It's actually the cognitive load, I think. That's the actual saving, because the problem with handover is, like, I've woken up in the middle of the night. I'm just a bit of a worrier, but I've woken up in the middle of the night and then called the on-call being like, dude, did I remember to, like, hand this thing over? I think I mentioned the wrong patient. Like, just go back to sleep. It's fine. But the problem is that cognitive load piece of, like, as I say, it relates to the whole of task management of the entire hospital over the entire past 12 hours. That's really what handover is. And so anything that helps might be 200,000 minutes over time, but actually I think it's probably just the feeling of the safety net and all. There's so much baked into that I don't want anyone listening to just think it's the minutes. Like, it really is. Oh,
less errors, less
yeah, exactly that.
So no, that's
Exactly
thanks
that.
for doubling down on that, James. Yeah, so it's more than the efficiency. It's about cognitive. It's that joy. Like, I don't have to now at the end of the shift write everything, remember, and
Joy. Yeah, what a word. Yeah, joy. If only we could bring some of that back into practicing medicine.
Now, coming back on the agent side, I think I get asked the question a lot. I believe 2025 will be an era of agents. We are seeing this moving at a much, much faster pace. But to your point, many people have seen GenAI in our normal day-to-day. We're using Gemini, ChatGPT, writing an email, whatever, right? We've been exposed to it. Right? So to me, the big difference is GenAI, in a very broader term, generates or creates new content. AI agents, they do, right? So generate versus doing. Think of it like GenAI, you give a prompt and it produced either a text, an image, an email, whatever you ask for. AI agents, on the other hand, are far more like skilled workers who can take initiative and get things done. They have a goal in mind and they can figure out the steps needed to achieve it, even if those steps are complex. That's where the workflow piece, James, that you mentioned is coming into play. And they are aware of the goal, they're aware of the steps that are needed, and they adapt to the changing environment. And to me, AI agents are going to rapidly transform how we interact with technology and the world around us. So they are the next step beyond simple automation, enabling computers to perform tasks, learn from data, and even make decisions, often with a level of autonomy that we haven't seen before. And that's where we need to balance the autonomy and oversight when implementing AI agents, especially in regulated industry like healthcare. So a very quick, simple example. When you tell your Google Home is free, book my alarm, like it's doing a task that you asked it to do. To me, that's the agency. They're doing work. And to me, in healthcare now, you can imagine, what if there are AI workers helping 24 by 7, hundreds of them, to nurses, to clinicians every single day? Now, it will bring the complexity. How do you manage them? And I think that's where a lot of work is being done on the technology side to manage these agents. First, understanding the difference between GenAI and agents, and especially in the regulated setting. Healthcare workflows are very prescriptive. They're rule-based. And how much agency do you want an agent to have? Maybe not a full patient-facing, but maybe if I'm booking an appointment booking agent, give them agency. Look for different things. So it will depend upon the workflow, the use cases, and that will be the balance between how much oversight you need versus the autonomy. And to me, this is going next 3 to 5 years are going to be all about agents across all industries.
That's exciting. It doesn't even sound optimistic. It sounds realistic given the pace of it. I mean, 3 to 5 years, you can definitely I can definitely feel that the agent model taking over the non-clinical side of so many processes. I think as long as we've got some baseline infrastructure that we're sitting on that allows for it, to your point earlier, I think that's incredibly important and actually becomes really urgent, I would say, because in the time that I've been in health tech, I've noticed something where when people in the community, when normal people have a technology, and the common one people talk about is online banking. Like once you have that, you then start to, in your normal life, think that, well, the fact I can't do healthcare like this is a bit annoying. It then goes from a bit annoying to actually, no, I'm going to start mentioning this when I go to the GP, that I've researched this app that might not have its accreditation, but I want us to use it. And all of a sudden you start to have this like bottom up demand, the more that healthcare drifts from the norm in terms of where technology is. Now, everything you've just talked about in terms of the pace of change means that I think unless we have that baseline level of infrastructure, and by that, I also mean a decent AI strategy of what our North Star is, so that we can actually focus on deploying and testing AI where we want it to versus where we don't. I also mean the actual technology platform to do so, as well as that group of people, perhaps, that I talked about per site, that's actually enabled to make decisions, because they're going to have to make those decisions very, very, very quickly. So I think that actually becomes urgent and important at this point, because I worry that healthcare is at risk of, I almost see it like almost like a white cell, like absorbs some of its prey, right? Like I feel like generative AI going around what healthcare actually is. And all of a sudden, people are literally just typing into their agent model, like, I've got this sort of headache. Here's my stuff. Or but even before that, it just plugs into my wearables, and actually, it's already agent telling me and acting for me about like what my prescription should be and telling me what I should go and ask for. So, like, healthcare is at a bit of a risk, I think, of falling so far behind that actually these structures, especially when you include, like in the UK, we've got the NHS middle, you've got private healthcare that can zip around the sides, that could actually run relatively efficiently, drop its prices, the insurance model drops its price, all of a sudden things start to change. Like, you're starting to see, like, Neco Health, people are going in their pockets for, MOTs, like, on themselves. Like, it's happening. Like, I see it. I see it on the non-clinical side. I see where it could go on the clinical side, and I don't know.
I think you're hitting on the point. I would say even like symptom advisor, I think that's more clinical decision making. Keep that. I think, again, healthcare will move at the speed of trust, but there are humble use cases. So as an example, let's say as a patient, let's say you're diagnosed with something and now you want to figure out who's a specialist, who covers your insurance, what is their rating like, and are they in network, not in my network, and you want to navigate that, and then you want to book an appointment, you want to match it in your calendar where you don't have any critical work appointment or your children's responsibilities. That task today of care navigation is a daunting task for many. And I can say, as a mother of two daughters, I have to juggle a lot of things. Now imagine, very few people in the world have this personal concierge. They're taking care of all these logistical things so they can do what they do best, but all this logistical booking, all that is taken care of. To me, that's the vision. Even if we stop that, I do not want an AI model telling me what I have or don't have, but I want them to take my day-to-day drudgery away from me. Help me figure out what's the best time to go to an appointment. Figure out from my calendar, my kid's calendar, my physician's calendar, my insurance policy, which is the best physician where I should be going, and book an appointment.
And is this happening? Are these moves happening that you see?
There are moves happening. The forward-leaning organizations are figuring out those use cases, which
Yeah.
are, again, this appointment making is non-clinical. It's figuring out my insurance policy, my network, out network, I think that's where they are starting from. Now take post-discharge, right? When I got home, surgery, we also have to think about now getting into, there's a term we call um, Turing's trap, meaning things we are augmenting today, like this appointment booking, care navigation, but what's not happening where AI can be a helpful partner to do that work. So think of things where we always think of, when you're discharged, you're home, can an agent, you can talk to them, hey, I'm feeling really groggy with my pain medication or my pain level has gone up. A companion for them to get through simple questions which are very important to me at that moment in time, which are more pathetic to me, where I won't call a nurse 10 times because I'll upset them. But I think there are things that are not happening today. People are left sometimes on their own devices to figure it out. And those are the opportunity areas, again, which are not diagnostics, non-clinical, but really like we talk about back office, and this is where I see them on the navigation side. Care navigation.
Yes. So here's a question then. With the age of agents being the next 3 to 5 years, as you put it, is this something that could really significantly help in the search for making healthcare sustainable globally? Is this something that can significantly drop cost in back office, in non-clinical? Is this something that streamlines healthcare? Is this something that potentially on the clinical side does actually drop the requirement for those 10 million clinicians globally? Is this something that changes the way that we organize healthcare? Is it something that genuinely changes roles and the human does become more empathic rather than someone that holds a load of facts in their head? Like, do you see any actual proof points of that movement towards that end?
Yeah, I do. I do see that where AI agents across not just healthcare, across all industries have potential to
Yeah, it's other industries. Yeah.
revolutionize whatever business transformation where
Yeah.
there's a lot of drudgery in our day-to-day work, James, right? So
Yeah.
more efficient, accessible, personalized. While there are challenges to overcome, as I mentioned, and I'll say it again, healthcare will move at the speed of trust, and that's where having that platform, how to evaluate these technologies, how do you have evaluation frameworks? Do you have a AI governance committee? Do you have AI principles? Like what use cases you'll pick or not pick? And to me, that's where some of the attention needs to go, where AI would require, especially it requires significant investment, both in people and technology, but figuring out what are the use cases, right?
Yeah.
Like, where are the highest ROI? And it can reduce long-term costs through automation, through this agents that we talk about. So if I have to say it, think of this as two-pronged, which is present forward and future back. Present forward, figure out what your GenAI strategy is. Like how many boards and CEOs have that strategy established. I think the number may be higher. Bain did a study, I believe it was a year and a half ago, only 6%. So we need to start with that. It's not just technology that your CIO will manage. This is truly thinking about business in the age of AI. Right, having the strategy. Second is, what are your principles for your organization? Like Google had our principles in 2018. It behooves the era that we are about to enter in or already in. What are AI principles for your organizations? You decide that. And third, use cases. Like, where is the ROI? Where is juice worth the squeeze? Like, we need to figure it out. And I think that's where it is across functional decision making than just a CIO or CTO play. But there's no doubt we are seeing it. Investing in AI thoughtfully, having the level of governance can position organizations for long-term success. And McKinsey did also a study that people who are experimenting and have this advantage, it will be disproportionately advantageous for them in long term to be thoughtful investing in that.
Yeah. God, I definitely agree with that. It's going to be a heck of a watershed. Aashima, this has been wonderful. I do want to end it there actually, because I just want to reinforce what you've just said, that thinking of where we are now in two ways, present forward and future back. And when thinking present forward, to really consider what are your AI principles and do the work to figure out what are the use cases. I think that is so important. And that actually really neatly, I guess, gives me an answer to a frustration that I've had of like, where does one start when trying to think about this? And I've felt the frustration of a lack of an overall AI strategy, but actually no, devolve the power. Like, as an organization, you decide your AI principles, you decide your use cases, and then we can look towards evidence and all the rest of it beyond that. But at least when we're clear on what we want, the market and the industry can then respond to that, rather than, I think, what's happening now, where industry is just being quite technology led or just artistic ideas led of like, what could this be? Quite future back, I guess. The other thing is to consider future back. I think for organizations, I think for technologists, I think for people building, I think for health tech startups listening, I think for clinicians listening, thinking future back is also important. Probably if you're a clinician as well, thinking about the self, thinking future back is probably quite an interesting thing to do, because if I'm a clinician sat now with a full-time job, that when I think about it, could you string together a few agents to actually do at least part of my job? Then maybe I should be thinking about integrating with this stuff and really staying abreast of it, so I can start leading on the design of the protocols and of the architecture of the agents setting up. And could I, as a clinician, think about how a group of agents could come in and do that? That gives me a really interesting position in the market. I know a lot of people listening have probably DM'd me at some point in the last 6 years of this podcast asking, how do I get into health tech? I think that's probably quite a good way, is actually thinking about this stuff. So really thinking future back and what's your position as a clinician in the new world. And the new world order. I think it's what a fascinating place to be, Aashima. What a wonderful job that you have. It's been an absolute pleasure having you on. For people that want to learn more about anything that you've just talked about, if they want to get in touch with you, if they want to learn more about what Google Cloud are doing, what's the best way for them to get in touch with either you or Google?
I'm going to say read up upon cloud, our products, Vortex, search that out there in the public domain, reach out to me on LinkedIn. I'm on the Twitter as well. But I would say I would encourage the listeners to really spend time in really internalizing the moment that we're in, right? The urgency of the moment. And we need to make sure that AI is used ethically and responsibly. And how do you do that? You need to be experimenting with it. It's okay that if you're not that far ahead, enterprise AI is complex. So don't get discouraged by lack of speed or lack of pace, but experiment, right? Make it better by participating in it. Being on sidelines is not going to serve AI, humanity in general. So you need to be experimenting with that and guide us. And I'll share more links, James, with you on some of the links that they can read up, some case studies, how others have done it. Another call out or takeaway for the listener is share. Like healthcare also is these are common use cases if you think of it. Like navigation, every hospital system faces that. Every insurance company has that. So if you have figured out a model, where is the shared learning? So be open in sharing, in shaping it. We have a saying, first we shape our tools, then they shape us. How are we shaping these tools? So be experimenting, being in the action is much more kind of call to action.
Aashima, it's been a pleasure. Thank you.